assuming everyone can hear us there on the Teams call. Otherwise, and I'll post a recording of this somewhere if anyone wants to follow up later. This is a very important topic, I think, especially for doctors. I think that I think it's important for us to, and I'm happy to put my hand up to say that doctors really need to rethink some of our algorithms and some of the ways we think about this, and certainly the issue of treatment-resistant depression is one of those. So we'll get right into it. So there we go. So today, what we're going to talk about is, we'll think about understanding the evidence linking adverse childhood experiences to treatment-resistant depression, and I'll talk to you about a recent published study called the Swedish Twin Study that highlighted this. We're also going to think about the work of Martin Teicher and his colleagues at Harvard, and we'll talk about the concept of the ecophenotype, and that as a framework to distinguish maltreatment-related depression as a clinical distinct subtype, and then the goal being to really shift some of our clinical thinking away from medication-focused approaches to trauma-informed and multimodal care. And then we'll think about how this might apply practically. So firstly, treatment-resistant depression is quite prevalent. There's the numbers suggest that up to half of people with major depressive disorder will meet criteria for treatment-resistant depression. And now, what's the definition of treatment-resistant depression?
Proper trial with 2 antipsychotics and no significant improvement.
Antidepressants, yes. So the definition of treatment-resistant depression is failure of 2 antidepressants, right, with a reasonable time frame. That is the definition of treatment-resistant depression. So it's a very medication-based definition, and generally the treatment options become combining more than 1 antidepressant, combining 2 or 3, or adding an augmentation medication like an antipsychotic or a mood stabilizer or a stimulant to try and shift that depression. So that's the current treatment plan for treatment-resistant depression. The skeptic in me suggests that there may have been some industry that's driven that algorithm. But treatment-resistant depression is important because it's 30% higher suicidality, but we think that actually there might be other factors. It might not be just about failure of medication. Maybe there are other factors that we haven't yet considered that might be contributing to the person's depression not being able to be treatable or being resistant to treatment. And so this is where we start to raise this question that what if the depression doesn't respond to medication? What's going on? Is it not depression? Are we treating the wrong problem? Or maybe we need to think about a different approach, because what if it's a different type of depression? And so we need to think outside the square, because otherwise, certainly from my experience, when you increase the medication doses, use 2 different antidepressants, add an antipsychotic, it doesn't tend to lead to magical benefits. And generally, once you get past those 2 antidepressants, you really start grasping at straws until you've tried every antidepressant, and then you don't know what to do next. And I'm guessing there's a lot of people who would share that experience. Let's do a bit of a refresh on what ACEs are. So adverse childhood experiences was a really landmark study that looked into different types of adverse childhood experiences and then linked it to outcomes. And so those of you who haven't looked into ACEs, didn't look into the ACEs study, you really should. It was a study that linked that the higher the number of adverse childhood experiences you experienced in your life, the more likely you are to die early, the more likely you are to have physical health problems, the higher your use of the health system, the more likely you are to have alcoholism. It's one of the really big studies that shows that adverse childhood experiences have an impact on human life in general and health. And so there are a number of different types of adverse childhood experiences. So there's, which is categorized to abuse, emotional, physical, sexual abuse, neglect, emotional, physical neglect, and household dysfunction, exposure to family violence, substance misuse, parental mental illness, parents in jail, or parental separation. And essentially there was a really strong correlation that the more you had of these, the worse your life got. Not just in mental health, but in general. So it's a study that we still don't talk about enough, which is why I'm always bringing it up. Now, let's talk about this study. So there's this study called the Swedish Twin Study that was released this year in the Journal of the American Medical Association. Had a co-twin control design that involved 21,192 twins from the Swedish Twin Registry. So if you recall, the Swedish registry is one of the best in the world, where they've done a really great job of tracking all of their population and their outcomes and their health and all of the different factors so that they can study them. The definition of treatment-resistant depression is, as we mentioned, that you've had 2 antidepressants for at least more than 6 weeks, and there was no reduction in your depression. And so the key numbers in this study was that there was 17,000 twins in the analysis. 31% of them reported more than 1 ACE. 5.6% of them reported greater than 3 ACEs. And 230 of them, or 1.3%, met criteria for treatment-resistant depression. And 61% of those with treatment-resistant depression had more than 1 ACE. Now, a couple of things to note about these numbers, that this is about that cohort. Now, as we mentioned before, the rate of treatment-resistant depression that's quoted in the general literature is about 44%. So this cohort had a much smaller than the typical, right? But it doesn't mean you can't study them, okay? Because these were obviously twins in Sweden who consented to these, right? So we know, so in terms of in terms of, is this exactly the same people who we would extrapolate to the general population? That's not probably the case, but that's not the point of this study. The point of this study is, let's study these people who do have treatment-resistant depression, and what the purpose of the twin studies. Can anyone tell me why do we do twin studies? What's the purpose of doing twin studies?
You get two outcomes with the same biological and like the same genetic makeup as well as biological. Usually they're raised the same way.
Correct. So you're trying to rule out the genetic factor and the home environment factor as best you can, because technically they would have the same genetic makeup and living in the same home. So it means you can control for that confounding factor to some degree, which means then you can study the factor that you're looking at. Okay, so what this study showed is that with each adverse childhood experience that they had, then the rate almost was 1.7 times more. Any adverse childhood experience versus none raised your chances almost 4 times of ending up with treatment-resistant depression. And if you had more than 3, your chances were 7 times the risk of having treatment-resistant depression. And when you controlled for the twins, so this is one where there's discordant twins, where you have twins in the same household and only one twin had the adverse childhood experience and the other twin didn't, that still showed a doubling risk of treatment-resistant depression. Right? So what does that tell you? Don't be that twin. It tells you that there are other factors that we don't think about. That maybe this problem of treatment-resistant depression may not necessarily be related just to biology and medication failure. Now, not all adverse childhood experiences are equal. And the type of adverse childhood experience seem to make a difference. And physical neglect, so when you're a human being who didn't get cared for, that seemed to have a massive effect. Sexual abuse and rape as expected. But then emotional neglect, this is the bit that highlights for me, is that emotional neglect and exposure to family violence were actually worse than being physically abused at increasing your risk of developing treatment-resistant depression. What does that tell you?
It emphasises the Maslow's hierarchy of needs. The basic needs met, then the rest of the stuff is not as bad if you can meet the basic needs.
Yeah. And these are things that we don't ask about, or we don't do much about.
Yeah.
We often, how many times do we hear in our presentations there was exposure to family violence, and it's just a thing that we note. But it's probably more significant than we make it. Right? We know it does something, but this is one of those pieces of evidence that say, hey, no, that child is more likely, 3 times more likely, to end up with depression that won't respond to medications. Right? And that's where we look after children, and that's the point that we should be thinking about. Right? Because this study is looking at adults and looking backwards, but we can also do it the other way. And we have a responsibility, now that I've told you this, you can no longer not know this. Right? That you now have a responsibility that that's likely to happen for that person. Interesting, isn't it?
Do they class a event as a singular event? So like a child who maybe lives in out-of-home care, would that be classed as one abandonment time, or each time that happens as one?
This is the thing about ACEs, it's purely about exposure.
Yeah, okay. So you in that study, exposure, even if it happened 20 times, will be recorded 20 times.
Yeah.
Okay, cool. Right.
Right.
Wasn't like
but also once.
Yeah.
Right.
Yeah, once is enough, but
yeah,
that would compound.
Yeah.
Obviously. Yeah.
And that's an interesting question, isn't it? What's the dose, right? And you can probably guess what that outcome would be.
Assumed, yeah.
So we talked about this, that the strength of twin studies is it allows you to study the specific factor to try and control for biology and the home environment, and that the ACE score and the treatment-resistant depression association was still maintained, and that emotional neglect was maintained, and which suggests that adverse childhood experiences have an independent effect on this, not just biology, not just genetics. Now, if adverse childhood experiences drive treatment resistance, how do we think about what do we know about childhood adversity? So let's think about what's the mechanism of this. Right, let's think about how does it actually change the brain? And so for those who aren't aware, and I've mentioned it a couple of times in the past, but for those who aren't aware, Martin Teischer's group from Harvard have done a lot of really, really important work in this. So what their work started off as was they did some neuroimaging studies of young adults with mental illness, and they're the first to actually try and link the type of trauma that you have to the outcomes, to the mental health outcomes, but also to the neuroimaging changes. And where they took really detailed histories about the type of trauma and when. Okay, there are some really, there's some really, really striking results that they got, which is that, and there's a couple of links to this, but one of the highlights of their work was to identify that emotional abuse counts, and it actually causes a lot of impairment and a lot of changes on your brain. In particular, that when they looked at the risks of exposure to a particular type of abuse and the outcomes, the risk of developing depression, anxiety, but also changes in your brain, that verbal abuse from your parent is just as bad as being sexually abused by someone outside your family. All right? Now that we know that, it kind of makes sense. And verbal abuse from your peers, like bullying, wasn't too far behind, which helps provide an understanding for us why bullying leads to suicide. And it highlights the flaw in our system where we really only act if there's physical or sexual abuse. Our protective mechanisms, our protective systems don't act if there's emotional abuse. Don't act on persistent verbal abuse by the parent. That's not enough to intervene. That won't even get across intake. But there is evidence that causes significant impairment, right, in terms of depression, suicide, and in this study, treatment-resistant depression. So their group talked about an ecophenotype. What if there are different types of depression? And maybe the reason why our evidence-based treatment doesn't work is because it's actually a different type of problem. So here's the suggestion that maybe there's an ecophenotype. So remember, phenotype is the what we see as an expression of the genotype. So the gene becomes expressed into a phenotype, and hence this description that whatever your biology is, it's coming out in what we see. But what the phrase ecophenotype suggests is that maybe there are factors or the ecological factors, that there are environmental factors that affect the phenotypic expression of that biological problem, right? And that your environmental experience, specifically childhood maltreatment, while it might still fit under the diagnostic criteria of major depressive disorder, but what if they're actually slightly clinically different and neurobiologically distinct? So, and that what if there are two different types of depression, one with a maltreatment history and one without a maltreatment history, such that the depression with maltreatment history will have an earlier onset? I mean, in our population, we think about the depression that besets a 10-year-old, right, or a 12-year-old. The symptoms seem to be greater in severity. There's more comorbidities like anxiety, personality disorders, or substance use. There's a higher suicide risk, and there's poorer response to standard treatments. Right? And this is an attempt to say, hey, maybe we should think about this differently. This is not going to make the DSM, right? But it's an attempt to say that what if the maltreatment history actually makes their presentations, makes their problem different, which means we need to think about it differently. And it's a really good way to think outside the square. Now, how does maltreatment change the developing brain? Now, there's evidence of this, right? That it reduces the size of your hippocampi, right, which impairs your ability to consolidate memory with context, your ability to distinguish safe and threatening contexts. It impacts your amygdala function, where your amygdala becomes hyper-reactive to threat cues, particularly social cues. We know a few of those people. And you have enhanced threat detection, right? But and you know, there's a theory that maybe the enhanced threat detection is an adaptive way. It's and we've talked about this before, that maybe, you know, that our defense mechanisms are, well, they are. They're survival mechanisms, aren't they? But now, even though you're now in a safer environment, it will still drive chronic anxiety. You'll still be hypervigilant, and it impairs your cortisol system. You know, your chronic early stress reprograms your stress system, which can lead to inflammation, emotional lability, and potentially reduced responses to medication, because the medication is working on a serotonin system, but not directly on the stress system that's kind of causing your response. And then you can see, and this is something we've talked about many times, which is that, you know, there's an alteration in how your frontal lobe works or develops. There's reduced cortical volume, altered connectivity, less integration of your frontal lobe and your limbic system, which impairs your top-down emotional regulation. Right? Which makes sense. And that's what we see in the young people that we see. Now, what about medications? Remember that, you know, our definition of treatment-resistant depression is a medication-based one. So the SRIs target serotonin neurotransmission, but what if you've got a bigger problem than your serotonin neurotransmission, and what if it's not as effective because your brain's actually structurally different? Because as we've seen, that your brain development changes based on your experience. Your stress circuitry is not the same. You've got altered gene expression, as we know that your environment alters the expression of genetic code. You've got chronic inflammation, which we see in chronic stress. You've got lots of other symptoms of inflammation and allergy, for example. You've got impaired emotional regulation systems, and your trauma pattern is relational, where you're hypervigilant to faces, you're hypervigilant to people you find it hard to trust. So antidepressants can't rebuild neural circuits. It doesn't resolve attachment injury, and it doesn't reverse epigenetic changes. Right? And if those who haven't seen this, there's this Nemiroff study in 2003 where they analysed chronic depression treatment, and the patients with childhood trauma, the results of the treatment, the treatment algorithms were kind of turned on its head. That psychotherapy was actually superior to medication alone. Because remember that the traditional algorithm for depression is, if it's mild, you give CBT, and if it's moderate to severe, you add medication to CBT, right? And the time when and why you would use medication alone is if there's an absence of good CBT. Not when you're around, right? If you can't access good CBT, then you use medication from the start. But it's actually worth remembering that as well, because I don't think we actually use that algorithm very well either, let alone studies that turn it on its head that says psychotherapy was actually better than medications, and that adding medications didn't seem to add any benefit, but those without trauma histories seem to follow the typical pathway. Right? Again, these are things that we don't talk about but it's important for us to be aware that there are other schools of thought out there, and we need to think differently. We can't just think along the lines of the pharmaceutical guidelines. So, what would be a suggested shift? Currently, we say, oh, this depression isn't responding. Let me try another SSRI, because those two didn't work, and I've got another 5 to choose from. Maybe a bit less than 5. Or maybe we might add a different type of medication, like an antipsychotic. Oh, or maybe this is just one of those that's just never going to get better. 2, hang on a second, maybe this person has other factors like significant adverse childhood experiences. And what if their depression might be a little bit different to the ones that were studied using the medication? And what if medication alone is unlikely to work? And maybe we need to actually review whether the quality and the approach to psychotherapy, and that the medication is a secondary treatment to this type of problem as opposed to the primary one. What prevents us from thinking that way?
I know sometimes medical model, sometimes.
Yeah.
Yeah.
So what does that mean, Shane?
Medical model, in the sense that I suppose we have that thinking around that it's like genetic or biological sort of thing. We try medication, fix it, and it doesn't work. We try another medication, must be the right medication, and so we go down that path, and we don't sort of take into account perhaps all the other environmental or the other stuff which is going on around that. I think sometimes gets in the way of that.
It is, because we'd like the easy answer first, wouldn't we?
Yeah.
Right? What's that?
The quick fix.
Yeah, that if we can take a pill, and also it's confronting to think about our histories. It's confronting to think about our families. Right? I think it's fascinating that we even have to have this conversation, because humanity suggests that what we live through actually shapes who we are. But the fact that we've got to go, hey, let's think backwards instead of that being the primary thing that we should be talking about. But it's confronting. And it's easier for a human brain to hope that there is an external thing that I can take that will actually improve me. And that's also acceptable to some degree, because to a large extent, external things happened to me that made me this way. So it's kind of fair for me to expect that the world owes me, and that something outside of me must happen to fix me, just as something outside of me hurt me. You know? So we can accept that, but unfortunately for 44% of people, it doesn't work. Yeah. So what might be a framework that we can think about? So if we integrate Tasha's recommendations, we would, if you have a young adult presenting with treatment-resistant depression, you would need to think about, okay, what if this is a different type of problem? Right? It doesn't mean we don't use medication, but it means that we need to think about it differently. What about, have we actually considered where they've come from? Remember that whole saying of, it's not what's wrong with you, it's what's happened to you? Right? And there are a number of validated tools, but you don't even need to use validated tools. You can just think about and have a conversation with people. And if that's too confronting for them, then you talk about someone who talk about it with someone who knows them. Where have they come from? What's their story? How have they got to here? Right? What were the things that they got exposed to? And ask the less obvious things, like physical neglect. Ask the less obvious things, like household dysfunction, like parental mental illness, and verbal abuse, and neglect. We only ask about, how many times do we say, there's no trauma that I could identify?
Not often.
I said that last week.
Yeah, that's right. That's such a common thing. But this is a challenge for us to go, are we actually thinking about trauma in the way we should? Because there's really significant data that the traumas that we ask about aren't the only ones that matter. And there are ones that we never ask about that actually have significant impact on someone. And what if we then think about this? Because once you've got that, then you can start to think, what if there is a different type of this diagnosis? That what if the adverse childhood experience actually impacts the way that their illness will respond to treatment? And then you then shift your approach. We then need to double down on psychotherapeutic efforts, which is hard to get. And that's one of the other reasons why we go to medication. Because that's hard to get. And systemic change, like addressing the whole person, relational repair, thinking about family, thinking about sleep, reducing adversity, teaching your carers that this is your brain and you don't have a choice, right? That's hard to do. So, which is why I find myself prescribing lots of things so that the kid can go to school, because we can't do the other things. It's not just a lack of good CBT, it's a lack of good holistic care that we end up going to medication. And I can I'm very comfortably say that happens a lot. But we can't lose hope, and we can't give up on it, because the data suggests that if you don't do that, their depression doesn't get better. It doesn't matter how much more medication you give them. So it's important that we still stick by the framework. What about, how would you talk about this to a person? Right? What are some words that you could use? And this seems really obvious, but some people find it really hard. How do we talk about this? How do we say that what happened to you as a child may have changed how your brain actually developed? And the way your brain's developed was actually to try and protect yourself. It's an adaptive thing that you did to help you survive, which means your brain's become really good at detecting threats, particularly in people, like their voice and what their face looks like. And that was really useful for you when you were a child, because it meant you knew when to go away, when to hide. But it means that you've now carried that skill with you, and now you misread people. Now you assume that people are threatening or they're going to reject you or abandon you based on the sound of their voice or the look on their face. And this is not going to get fixed by medication. And maybe this is why your medication isn't working. So we need to find a way to work together to help your brain learn new skills, new patterns, through safe relationships, therapy, and through your own understanding of your own story, which then allows you to have this attempt at this magical thing called self-compassion, which seems so hard to attain for people, because self-compassion requires, a bit like co-regulation, it requires another who can help you accept yourself because they accept you. And sometimes 1 hour a week isn't enough to get there. Right? And so for us, what happens? What if you go the other way, where you actually see a child and adolescent who you know is exposed to adverse childhood experiences? What can we do? So, and we've said this many times before, where when you see someone who's got a really difficult mental illness as an adult, and you go, damn it, I wish we'd seen them when they were 13. I wish we'd seen them when they were 8. Luckily for you, you now work in a child and youth mental health service where you do see them. So now what? You actually do see them now, and you now actually need to do something about it. Right? You are that person. How would you do it? What would your approach be knowing this?
Talk to them about it.
Mm-hmm. What do you mean?
Well, you talk to them about their experiences and find out what they were, and then be able to help them through CBT or DBT, depending what therapy you're using, to create a safer space around that and a better understanding of what they've been through, and training their brain to think differently about threat.
Yeah, apply the paradigm. You have a different mindset because you know this now. And so you know that the path ahead for this young person is probably going to be a path towards treatment-resistant depression. So it's important that when you see children, that early intervention is not an option, right? And earlier intervention, really, because early intervention is prevention, but you still have a role, and you still have a very important role. So let's think about what some of your options might be. And let's think about it from a developmental approach, because Martin Taj's work actually shows that depending on the timing of your abuse, different parts of your brain get affected, right? And when your abuse happens when you're young, those really basic fight, flight, freeze systems, like your limbic system, that's the bit that gets impaired. When your abuse happens when you're a little bit older, so for example, verbal abuse from your peers, which makes sense, right? Because you're really vulnerable when you're young to verbal abuse from your parent. But what happens when you start to go grade 5, grade 6? You start to leave your parents and start to move towards your friends. Your sensitivity to their verbal abuse is transferred, right? So, and what happens is, it's a time, that puberty to adolescence is a time when your frontal lobe growth is really starting to happen. And so what tends to happen there is that's the part of your brain that gets impacted when the abuse happens then, right? And look, it's a general safe rule that the earlier you get abused, the worse your outcome's going to be, right? The later, somewhat protective, but still potentially quite impairing, right? But it means that your approach can be a bit different. So when you see someone who's young, who's already experienced adverse childhood experiences, you know that their fight and flight, that limbic system's going to be the bit that's going to get impacted. So that's where you target your support. That's where you target your treatment. That's where you target your intervention. And what are the things that help that? The same things that a baby requires to develop, right? Because that's what they're learning. So you need to double down on those and repair and undo those traumatic experiences like neglect or lack of co-regulation or parents who are dysregulated. They're the things you need to undo. So you need to support that parent, but also add other. So how many times have we said that if we don't have healthy brains around that child, we need to find healthy brains around that child and add them. And some people are lucky because they might have a healthy grandparent brain, a healthy aunt brain, or an uncle brain that offsets that experience of their parent. So your intervention for that young child is to add healthy brains and create safe, predictable environments. That's the number one intervention. It's hard to do that without addressing the parent's mental health, which makes it really difficult when you're a child mental health service who says, we are not the adult therapists. We only see the children. There's a bit of an issue there, right? But, which is, thankfully we're starting to address after transformation. We've now got infant, child and family services, which is supposed to be able to support the parent, right? I'm not sure we're quite there yet, right? Because we should be doing parent therapy, not just education of parents through groups, actually helping that parent's brain heal. Because they're going to be the ones who are going to be responsible for creating that safe, predictable environment. And all of your work needs to be attachment focused. Right? Parent, family first in that young child. And as they get older, a bit like the child's development, you get to work more with their individual brain. And this is transition, and this is sort of transitional period between 7 and 12 where there's a variation because their brains are starting to become more cognitive, they're becoming more logic-based, so you then have to make that call when to make that transition, right? But this is going to be the time where they start to transition towards friendships more than parent influence, which is why these school-based supports and social skill-based interventions become really important. What are they? They don't exist, for the most part. And that's a major problem. So now we see the adolescents with big problems because the transitional bit hasn't been thought of. We don't have those. How many times do we whinge about the lack of support for schools? Especially in that age group, in that grade 4, 5, 6. We might think about, when the preppy is hitting someone, but in that grade 4, 5, 6, there's a lot that happens in the schoolyard that we don't even know about. But that's the time. This is where these school-based supports. We're trying things like GPs in schools, mental health nursing in schools, but and so I do feel like they're a bit token attempts, real drops in the ocean attempts that may not necessarily actually make the difference that we're hoping it will. And then as the child gets older, and if you see them at 13 to 17 and you know that they've had exposure to adverse childhood experiences, you can then start to think about more cognitive-based approaches, right? You might think about DBT, then you need to start, and you might need to think about, you're always going to be trauma-focused psychotherapies, but then you need to face other things like assume that the risk of substance use is going to be higher. Address that as early as possible through trying to head off the self-medication role of medication of substance use, right? Because that's how you prevent that. By and large, people are using the drugs to cope with something, So there are different things that you can do at each stage, right? If you're seeing them at each stage, there are things, and so the takeaway message is that, if the abuse happened early, you really need to think about safety and those non-verbal signals to the limbic system. And as the child progresses through their development, you can start to use more cognitive-based work, right? But we still have people doing CBT with 6-year-olds and 5-year-olds. You go, what? Okay, and there'll be 14-year-olds whose developments have been incredibly delayed, and you still might not be able to use cognitive-based therapies if you've got neurodivergence, for example, or you've got speech and language problems, because there's been a significant impact to your development. Any questions or comments about that? Okay. And this is that reminder, right, that the timing of abuse really has an impact on what part of your brain. And this has been reviewed multiple times, and even again, I think they even re-released this again in 23. The findings have been quite consistent. That there are distinct windows of vulnerability. The type and timing and duration of adversity shape your brain, right? And the message being that deep brain circuits get impacted when you're young. Why? Because they're the ones that are mostly developed. The other ones haven't really developed yet. And then as you get older, then the development of those circuits become affected. There are some tools. We all love tools. If having a human conversation isn't enough for you, there are some validated tools, and it's okay because we do want to have evidence base in our work, and there are validated tools where, like the ACE questionnaire and the MACE, which is much more detailed, takes about 20 minutes to do, but it captures the timing and the type and severity. And then there's also the childhood trauma questionnaire, which is again quite detailed. I would probably think about these. So I'm thinking about using these for children in child protection, where you can sort of really try and be a bit more detailed to see, because the kids in child protection have got so much experience of abuse that to try and find something that you can focus on, or that you can help predict who's going to be resilient, who isn't. You need to really kind of try and really dig down to detail. But the idea here is that you've got to think about adverse childhood experiences in everyone you see. And I know it sounds weird when I say things in our clinical review like, I don't care what the diagnosis is. It's because it's not as important as we think it is, right? It's important. Obviously, diagnoses are important because they give us an algorithm. They give us an evidence base. But what this talk is about is sometimes that evidence base doesn't explain it all either. Because what happens when the evidence base doesn't work? We blame the patient. You must just have one of those problems that that our treatments don't work on. Must be you. Yeah, right. And every time, as much as possible, we try and bring this narrative to patients and to people that the things that happen to you and your experiences actually matter. Right? Documenting things is important. Right? Because there are going to be certain things. So, for example, in the last week, we've had to think about a letter that I've written when Mum asked for that letter, and the interviews with the grandparent who really recounted a lot of things, and we had to think about how useful would that be for the mum to read that, and we had to act protectively, that it would actually do her harm if she read all of that in a letter. And that information needed to be discussed in person, in a sensitive way, in an accepting way, that she was also doing her best from her experiences. Right? So there's obviously nuances to how we take this history and how we think about it. So if we try and think about this, well, how would this impact? What if you had a person with depression, and what would you do if you found, when you took a sensitive history and decided that, okay, maybe this is one that has significant adverse childhood experiences, that therapy first, and that it's not going to be, you can almost already assume that it's not going to be it's not going to be responsive to traditional medication treatments. And this is interesting. It's an interesting concept to think about. Well, you know what? Maybe this is one that we need to go straight to the top, along with your psychotherapy, right? So even if we add the medical model, even if we think about it from the medical model perspective, right? That goes a little bit, that challenges the typical algorithm for a bit, and I'm not sure many psychiatrists would go straight to an SNRI. A lot of GPs do, but there are other factors related to that, like marketing of the medications. So, for example, desvenlafaxine is the most commonly prescribed antidepressant in Australia, and that was a brilliant marketing strategy where because normally you used to get sample packs that were only a week's worth, and with Prestique you got a month's worth. So the patient will get a month's worth for free. Brilliant. Became the most used antidepressant. Mm-hmm. Right? But that's an SNRI. So it is possible to go straight there. So maybe it's not so bad to go against typical algorithms. But it's important to think about that maybe this person with depression is not going to respond in the typical way that you expect them to. And to finish with a bit of a practical thing that, that this is a typical story that even a person in their 20s who's been on many different SSRIs. I mean, how many of our 14-year-olds are on SSRIs already? By the time they're 20, they've already failed 4. Right? They've got social anxiety, disordered eating, never sleep, self-harming, presentations to ED, and careful history, you start to realise that it started with emotional neglect, right? That there was conflict, or there was postnatal depression that was never supported enough. That there was, that there was socioeconomic factors that meant that they were often left unsupervised, and the family was quite poor and couldn't afford good nutrition, and then which made them vulnerable, right? And by the time they hit school age, they get bullied, they're really scared of people, and what happens? The sharks can smell your fear, and you get abused some more. And you don't like school, and then you change schools a lot, and your depression's just too bad because the medications haven't worked. How common is that story? Right? It's a very, very common story. So maybe we need to think about this, that, maybe this isn't about a depression that doesn't get better, that's treatment resistant. Maybe this is a different type of, maybe we need to think about depression differently if you've had adverse childhood experiences. In fact, that maybe your brain's different and that's why the medication's not working. Because we've actually understood your problem differently. And that we actually need to shift our approach. I know it seems weird to say we should actually prioritize psychotherapy, because we say we always do, but do we? Do we? I'm not sure we do. Because prioritizing it means making sure it's good, it's available, it's supported, someone takes you there if you can't go. What do we say? They didn't really engage. And that's it. That's all we say. We don't go, no. We need to help them engage, because it means they're scared of the therapist, or they're scared of the therapy. And they probably still have unsafe relationships in their world. And we need to look at that. Does that make sense? We really do need to think about this slightly differently. And so if you see a person whose depression or any mental illness is not getting better with medications, go backwards, because you've missed something. So this study, which highlighted it for us, is this registering study, highlighted that ACEs are independently associated with treatment-resistant depression. Taish's ecophenotype idea is important to think about. That what if it's a different type of depression, actually biologically different type of depression, and that's why the treatment didn't work, and that medication alone is unlikely to help it, and psychotherapy actually is the primary intervention, and you need to do it properly. We need to think about ACEs. I'm going to keep saying it over and over and over again until it really is something we think about early and routinely, particularly those that we don't ask about a lot, like verbal abuse, physical neglect. And for us who have the privilege of working with children and adolescents, we actually need to do something about it, because we've got evidence that the outcomes are worse. What can you do tomorrow? Think about ACEs. Think about asking those questions and screening for it. Think about childhood adversity before you switch medications. Think about the person's brain and development rather than this is the wrong, rather than treatment resistance. Actually think about how do we provide good psychotherapy and intervene early as much as possible.